Hey to everyone. Welcome to the CELA Speaks tonight. Tonight, our distinguished Dr. Dharmesh Patel is going to be speaking with us on, on secondary causes of high cholesterol. Dr. Patel is obtained his medical degree at Guy's and King's College at the Medical School, University of London in the UK. He's a faculty member at Stern Cardiovascular Foundation in Memphis, Tennessee. He's the director of Stern Cardiovascular Lipid Clinic and also the director of cardiac rehabilitation at Baptist DeSoto Hospital in South Haven, Mississippi. He serves as a board member for everyone here at CELA and the American Society of Preventive Cardiology. He is board certified in multiple disciplines, including American Society of Hypertension. He is also the clinical professor of cardiology at the Baptist University College of Osteopathic Medicine in Memphis. He is the current president of PACH, the Partnership to Advance Cardiovascular Care, and he has served as the principal investigator on multiple studies and has been published in multiple journals. But the most important part of all this is he's played rugby around the world and has climbed Mount Kilimanjaro. So a couple of housekeeping messages. So the link to CME will be in the SurveyMonkey link in the chat section. And please address any questions for Dr. Patel in the chat section. And I will go through those towards the end of the talk. All right, without further ado, Dr. Patel, thank you so much.
Kelly, thank you, and good evening, everybody. I'm not going to make this too crazy long, but I kind of, this topic resounded to me about 10, 15 years ago because we all talked about treating high cholesterol, but no one ever really discussed, well, there sometimes are other causes of high cholesterol. So when I was taking lipid boards and other things, I really got interested in the secondary causes of high cholesterol. And as a result, we're going to talk about that. So the four causes, or the 4Ds, I say, it's pretty basic stuff that you all very well know, but we'll go into them in a bit more detail. What I'm going to do is to try to highlight some of the secondary causes. I am going to bring in some clinical examples because I think seeing patients and clinical examples always renounds a bit better. So as you're all aware, diet is a part of that equation. Drugs certainly do play a role, and I'm going to share some of my clinic patients that have had secondary causes from drugs itself. And then, of course, we always seem to forget other disease states. Some of those disease states you can see here: renal failure, nephrotic syndrome, and Cushing's. But these are disease states that if you, quote, don't treat the underlying pathophysiology, you will never get the cholesterol to goal. And then, of course, metabolic syndrome or insulin resistance, a issue that is quite rife in the USA today. So, when you talk about dyslipidemia, I think it's important that there's a whole different screen on the treatment of dyslipidemia in terms of the therapies that we all are very well averse with: statins, bile acid sequestrants, ezetimibe, PCSK9s, inclisiran, etc. Those therapies we all understand, but I just want to highlight the fact that this is really a cardiometabolic syndrome, and the fact that there are other players in this game that we sometimes forget about. Because, for example, if I'm in a very busy clinic and I see a patient's LDL is, let's say, 150, I may say, well, or 140, I may say, well, let's just double up the statin or add ezetimibe or add a PCSK9. But please remember that if you don't look for some of those secondary causes, you will treat the underlying pathophysiology. So first and foremost, let's talk about diet. The fact of the matter is only 3% of America follows the 3 7s of the AHA. Don't drink, don't smoke, eat well, don't have diabetes, have good blood pressure, etc. So diet is key. We want about 7% of total calories in less than 7% in saturated fats, dietary cholesterol less than 200 milligrams. And, we tell our patients that exercise and diet are very important, but unfortunately, they only do, generally speaking, reduce LDL by about 15% or so. Viscous fibers, of course, decrease the absorption of cholesterol, 20 to 25 grams in terms of legumes, prunes, grains, lentils. And then sterile stanols, 2 grams, they can reduce your LDL. And of course, red yeast rice, we all know about the naturally occurring lovastatin. It can reduce LDL by 20%. I had a patient today tell me, well, medicine should reduce cholesterol, right? And I said to her, no, unfortunately, 25% of your cholesterol is ingested and the other 75% is made by your body. So some, interesting trials that have been done. I think the bottom line is this: when I talk to my patients, I talk about the fact that I'm going to stick to this. The Mediterranean diet to me is probably the best well versed and studied. There's been all these different trials with their different names of different diets. I have to say that it appears to me, I'd like to hear from my colleagues, the Mediterranean diet appears to be one that's pretty well received by everybody. And I say a common sense diet, avoid your carbs, um, avoid the fats, reduce your whites, your bread, your rice, your potato, etc., and that will do you in good stead. Fruits and vegetables, of course, are key, and we have two studies, the health professional follow-up study and the nurses health study. The fact of the matter is quite simple. The patients who are in the highest quintile of fruits and vegetable consumption had a 17% lower risk of CHD. So, this again further resonates with the Mediterranean diet to an extent that this is key. Now, nuts is another interesting little area to talk about. Yes, there have been data show that nuts being eaten 2 to 4 times a week reduces cardiovascular risk by 13%. I think it's important to understand, especially when you're eating certain types of nuts. In this case, almonds or walnuts are in particular pretty good, I believe, compared to some of the other nuts, which may not be so good. So I tell my patients, if you're hungry, maybe take a handful of nuts to kind of take you from that 2 p.m. to 6 p.m. region when you kind of want to snack and start eating bad foods. And yes, interestingly, there's been some inverse relationship between nut intake and causes of other morbid issues. I don't know how you are, but this is what I tell my patients. I like them to avoid as much meat as possible, especially red meat. And you may say, Dharmesh, well, how do you get that figured out? Well, I do feel that, I say stick with the whites, eat fish, chicken, turkey in particular. There has been a moderate positive association between meat consumptions and mortality from cardiovascular disease and cancer. And, we know that daily consumption of meat was independently associated with a 40% increase in all risk mortality. This is the one that I've stuck to most of my career, the Mediterranean diet, an astounding study of about 24,000 patients. And yes, those patients who had high fruit to nut intakes, legume consumption, a moderate amount of alcohol, 17% were due to low intakes of meats, and then, fats to oils having a high monosaturated to saturated lipid ratio, these patients did better. So generally speaking, I feel that the Mediterranean diet to this day has held firm on one of the best diets to maintain. Now, these are therapies that we see in our clinic every day, diuretics, beta blockers. The transplant patient is always a tricky one on cyclosporin. Ladies who are taking estrogen for menopausal type symptoms, anabolic steroids, retinoids, and protease inhibitors. So these are some of the culprits that we do see on a day-to-day basis. And, I'm going to have some examples of this, but I thought I'd make this a bit more interactive. Chronic liver disease, primary biliary cirrhosis, renal failure. Don't forget nephrotic syndrome. Don't forget Cushing syndrome. And the one that I really am concerned about in clinical practice is lupus. I mean, lupus in itself independently increases cardiovascular risks by an amount that you will not imagine later on. So this dyslipidemia, of course, is insulin resistance. As we all understand, diabetes is doubling every 10 years. There's about 44 million diabetics. It's going to get up to about 60 to 80 million very soon. And the reason for this is childhood obesity and inactivity. Unfortunately, exercise is not really a part of the childhood activities tree anymore. It's swiping their finger on an iPad or an iPhone. So this, unfortunately, is the reality that we have. And this is the reason why childhood obesity is so important. So I kind of wanted to make this a bit more fun, and it's not really, I mean, unfortunately, I'll be talking, but I hope you can kind of correlate to this. So, I want to talk about examples. I think examples always resonate better. This is a 74-year-old lady. She came in for high cholesterol. Her LDL had been 192. Earlier it was 120. She was followed up by me. Her atorvastatin had been increased by her primary care doctor. She now had some muscle aches, dry skin, a bit more fatigued, and she got a second opinion by myself. So if I was to show this a medical resident, The total cholesterol was 315, LDL was 192, HDL was 46, and triglycerides were 145. The point I want to make here is that, the initial thing is, your gut reactions, well, start a statin, or did she have a family history of premature CAD? But the right answer is really, did we forget about the TSH? Because, in that lady, she came in with fatigue. She had some dry skin, bradycardia, and, TSH and hypothyroidism. You do a decreased hepatic lipase activity. There's a reduction in LDL cell surface receptors. So the thing that I tell all the residents is please, please make sure you exclude hypothyroidism in every patient who's an LDL greater than 160. It was really embarrassing for one of my colleagues recently. He sent me a cabbage patient. LDL was 180. He said, Dharmesh, I've tried everything. I can't get it down. I simply just checked the TSH. And since that day, he's been really embarrassed to talk to me, but he won't refer any more patients to me. And so, the bottom line here is treat the underlying thyroid and then come back and revisit those cholesterol numbers. And as you can see, when this patient had their thyroid fixed, their LDLs was significantly better. This is a patient that, we see in the Southeast states all the time, Afro-American patient population. He has got some leathery, thick type skin in the neck region. This is acanthosis nigricans, indicative of insulin resistance. So in this patient, his cholesterol is 185, L is 138, his triglycerides are elevated to 90. And you can see, interestingly, his BNP is 244. And why do I even raise that? It's because he probably is on 2 or 3 antihypertensives. He probably has an element of diastolic heart failure. And please, please do not forget sleep apnea as the #1 cause of resistant hypertension in the United States. So in his case, he probably has metabolic syndrome, abnormal obesity, dyslipidemia, insulin resistance, and high blood pressure. And as I mentioned to you earlier, this is a pandemic. Unfortunately, it's doubling every 10 years. It increases risk of diabetes 5-fold. So, we really need to get a grip on lifestyle and things like that to help these patients. So what is insulin resistance versus diabetes? There is an increased production of VLDL over triglycerides. There's a low HDL and increased production of non-HDL, ApoB and LDLP. Remember, for all us lipidologists, and we talk about, which one's better, ApoB, LPLP, non-HDL. The fact of the matter is patients who have diabetes have a certainly higher number of ApoB particles or LDL particles. It doesn't matter which one you compare it to. So there is some discordance compared to the cholesterol. And, in this case, and, this is kind of interesting. We have changed our practice. We don't look at the HbA1c at 6.5 and say, aha, you suddenly have diabetes. You even know when your HbA1c is 6.3, 50% of your beta islet cells are not functioning. So, you're really into diabetes. And I think as healthcare professionals, we need to try to start weaning and treating those patients aggressively. One way of possibly doing it, I would say, is using the oral glucose tolerance test. But to be honest, in today's clinical practice, I would strongly consider metformin in that situation, treat them early on. But the point was the skin, the thick, leathery skin would be consistent with acanthosis nigricans. So this is case number 3. This was a lady that was referred to me for leg edema. Interestingly, though, her leg edema became quite significant. She had new onset eyelid edema and her creatinine increased to 3.2. So, you're in clinic, you get these labs, total cholesterol 215, LDL 163, HDL 52, triglycerides 333. There's one piece of information that we must remember before we start thinking about statins and possibly fibrates, possibly fish oil capsules, etc. And that's the fact that you need to check the 24-hour urine, because in this case, she had a 3.6 gram of proteinuria in 24 hours, which would be consistent with nephrotic syndrome. So a greater than 3.5 grams per day of proteinuria. She had hypoalbuminemia, hyperlipidemia, and edema. And this is due to the upregulation of diacylglycerol acetyltransferase activity. And it's caused by 2 factors, hyperlipidemia, because of the hypoproteinemia, because you're losing all the protein in the urine. It stimulates liver, resulting in overproduction of lipoproteins, and then the lipid catabolism is decreased due to low levels of lipoprotein lipase, the main enzyme. Remember, these patients have increased production of thrombin, and basically they have increased hypercoagulable state. So this is why nephrotic patients get DVTs, etc. This is another case that I've seen, a young college girl who basically had cholesterol numbers which looked like this, and you're scratching your head. And you ask, why is your LDL so high? Is there a family history? And she says, no, there's no family history. Of course, in someone whose BMI is quite close to normal, one would certainly think about anorexia. It can cause hypercholesterolemia, and the hypothesis includes changes in thyroid dysfunction, decreases in the endogenous cholesterol synthesis, and a high LDL and normal triglycerides. This is a case where I've become the #1 successful OBGYN doctor for fertility simply because we are missing the diagnosis of PCOS, right? A 32-year-old lady, inability to conceive, gained 30 pounds, TSH is normal. You get a pelvic ultrasound, and she has an ovarian cyst, and she has a triad of anovulation, excess androgen activity with hairs maybe around the chin, and then polycystic kidneys confirmed by ultrasound. This is due to overproduction of VLDL linked with insulin resistance, certainly. And it's the 5% of all women and leading cause of infertility. So something simple as just diagnosing this and treating it can reverse infertility quite tremendously. And of course, you do want to exclude other causes such as hyperprolactinemia, hypothyroidism, etc. So that's just a picture showing those polycystic kidneys. And the appropriate treatment is, low glycemic index, low carb diet, statin, metformin, niacin, but you do not want to give solazolam. This is a patient in the ER, get a phone call, and yes, certainly, you can see the ST elevation, the anterior leads with reciprocal inferior changes, consistent with, I'd say, an LAD STEMI, and confirmed by cardiac catheterization, where they've got a 95% prox LAD stenosis. And why am I talking about this case? The reason I'm talking about this case is because you have to understand that you can have a low LDL within 24 hours of acute coronary syndrome. So I've never understood why we want to check the cholesterol in the setting of acute coronary syndrome. And remember, the acute phase response is lower LDL cholesterol by 40 to 50% and return to 4 to 6 weeks. So this is why I never trust the cholesterol that's given to me in the hospital. I always look at checking it back in about 4 to 6 weeks' time. Now, case number 6 is something that we see quite often too. A patient that comes with dyspnea, let's say he's at COPD, he's taken steroids in the past. You can see his puffy face, red cheeks, etc. He probably has high triglycerides confirmed by this lab report. So the point here, the learning lesson here is this patient most likely has Cushing syndrome, okay? Severe elevations in cortisol level and lipoprotein overproduction. Triglycerides and glucose are elevated. And, you can see in this case, the patient has central obesity. He's got fat pads, and this is a nice little mnemonic for all the things to look for in Cushing syndrome. The increased 24-hour free cortisol level is one of the key diagnosis markers, as well as possibly doing a dexamethasone suppression test. They have the striae, the increased infection due to suppressed immunity. They have the hypertension, hypercholesterolemia, hirsutism. And then think about, is it caused by steroids, or is it caused by neoplasm, and is it glucose intolerance and growth retardation? So, a lot of our COPD patients who kind of were having a difficult time treating in terms of high triglycerides extra, it's considering the 24-hour urine-free cortisol level, or consider doing the 24-hour dexamethasone suppression test, or sending them to endocrinology, because Cushing syndrome certainly is a lot more common than we think it is. And, these are some of those exam question type clinical features of Cushing syndrome: thin skin, easy bruisability, red striation in the abdomen, buffalo hump, moon face, red cheeks, etc. Case number 7 is a gentleman who I saw in the hospital. He's got a triglyceride level of 3,500. He's got central abdominal pain, tachycardia. He's got fever. And, this guy has this on examination. He's got some discoloration around the umbilicus. He's got some discoloration around the flank. And these are 2 classic signs for Gray-Turner syndrome, where you have hemorrhagic bleeding into the abdominal region. And then you can have some hemorrhagic bleeding with the Cullen sign into the flank. This is pathognomic for significant acute pancreatitis. And of course, hypertriglyceridemia is the #3 cause of pancreatitis after alcohol and gallstones. You can see that the triglycerides can be up to 1,000 or higher, and it's caused by the breakdown of triglycerides into toxic free acids by peptide lipases that are causing lipotoxicity, causing acute pancreatitis. So, of course, in this case, the initial aim is to treat the pancreatitis, NPO, yes, maybe you want to start reducing the triglycerides, but I think the primary treatment here would be to treat the pancreatitis. Now, this is a patient that I know we've all seen in our clinic, a young guy, or even an old guy, to be quite frank with you. I think it doesn't have to be a young guy. Irritable. He comes in, his triglycerides are elevated, his HDL looks pretty okay. LDL is 120, glucose is normal, and it could be due to alcohol because you have to remember, you have to ask our patients, especially in hypertriglyceridemia. I think about diabetes, I think about diet, and I think about alcohol. You know, alcohol does increase stage by 10%, inhibits the CEPT inhibitor, it stimulates ApoA1 and it increases triglycerides. So you have to really get to the bottom of it. I had a lady today, classic. She was a lady who was working. I had no idea she drank alcohol. And at the very end, I said, "Do you drink alcohol?" She goes, "Yes." And then I knew she started breaking down today. It was a true story. So she started drinking half a bottle of spirits a day. And I said, "Well, you're not going to get your blood pressure down and your triglycerides under control if you keep drinking." So a great example of someone that didn't want to talk about it, and I kind of got it out of them that they were drinking, and that was some of the reason for the dyslipidemia. This is something that I've seen a lot, and I know you have too. Young people, they look great. They walk into your office, they look muscular, they look great. I mean, they don't even have any of this acne or the baldness. And you look at their cholesterol, and you're scratching your head. Their HDL is very low. The LDL is high. And in today, I've seen a lot of these patients have high calcium scores. So they look like a monument of health. And basically, I find out that, looking at the HDL and other clues that yes, these patients are certainly taking anabolic steroids. And I've noticed, and I'd like to hear your opinion about this, but a lot of these patients do not have normal calcium scores. Their calcium scores are elevated. And this is why anabolic steroids is controversial, especially in this kind of situation. Yes, it causes good development of the muscles, but severe acne, high LDL, low HDL, which is a very bad prognostic finding, that ratio. And then, it's present with liver disease, possibly gynecomastia and baldness. But please do not forget to ask our patients about anabolic steroid use. This is a lady who is 51 years old. She's referred by OBGYN. Her BMI is 27. No other medical issues, but something's changed. Her triglycerides have basically tripled from your last visit or 2008. And you're thinking, what happened? And, in this case, what happened is she was seen by the OB/GYN doctor. She was having postmenopausal symptoms and she was starting the oral contraceptive pill. And of course, as we all know, estrogen does stimulate hepatic production of VLDL, inhibits hepatic lipase, lowers LDL, and increases the HDL and increases the triglycerides. So an option for this lady possibly is to switch to the transdermal patch and cause hepatic second pass through. This is my favorite study, and I'd like to hear your thoughts on this too. This is a patient I saw 6 months and then in follow-up. In 6 months, his cholesterol was 231, triglycerides 187, HDL 41, LDL 121. And then I saw him 6 months after that. His numbers looked about the same, but one thing changed. His HDL had dropped quite significantly. And I was doing some advanced testing then, and you may or may not disagree with that. And his MPO and his CRP was significantly elevated. And so I knew there was something going on in the bloodstream, and his HDL had significantly dropped. The learning point I want to make here is that I actually did go ahead and check a CBC. And what causes a drop in the HDL? Well, you can get a drop in HDL if you add a glitazone is added to the fenofibrate. That can cause it. It can be a lab error, which is certainly reasonable. It can be due to acute illness. It can be also due to cancer or lymphoproliferative disorders. There has been studies of this. So I went back and got a CBC with differential, and this patient had a CLL. So the learning point here was the low HDL was not due to the fact he was not eating good foods or he wasn't exercising, but this patient actually had an acute lymphoproliferative disorder, and that paradoxically dropped the HDL. This is something we always forget about. What about those disease states that do cause dyslipidemia? Lupus disease, psoriatic arthritis, rheumatoid arthritis, all these disease states, rheumatoid arthritis triples the risk of cardiovascular disease and certainly does cause dyslipidemia too. This is one of my favorite slides from my medicine boards. Lupus is a bimodal pattern, and patients with lupus are at the highest risk for premature atherosclerosis and MI. This is what baffled me. Women with lupus aged 35 to 44 are 50 times more likely to develop a cardiovascular event. Risk factors include diabetes, hypercholesterolemia, as well as lupus itself. And, think about it. Lupus is an inflammatory disorder. Inflammation causes oxidation. Continued inflammation causes plaque formation and then ultimately plaque rupture. So lupus, I have a different respect for lupus. I have a different respect for all inflammatory disorders, rheumatoid, SLE, psoriatic arthritis. These patients have to be watched very, very carefully. So, what does cause an increased LDL? We discussed hypothyroidism. We discussed nephrotic syndrome. Primary biliary cirrhosis certainly can do it. Anorexia. I did not talk about HIV too much, but it's very, very important that you do think about it when you have those heart therapies. Very common, very well seen. In that situation, I've used a fair amount of pitavastatin. We talked about Cushing's, lupus, PCOS, and pregnancy. I generally don't treat patients during pregnancy except for fish oil capsules, and then treat them after their pregnancy. And then, what raises LDL? Anabolic steroids. Please don't forget to ask patients about anabolic steroids. Therapeutic doses do not classically. And if you have a transplant patient, such as one on cyclosporin, fluvastatin is reasonable in that situation. Progestins can, thiazides can, fibrates, and of course, prescription omega-3 additives can do it as well. Conditions that raise triglycerides, we've discussed: inactivity, low-fat diet, high-carb diet, alcohol excess, all cause insulin resistance. And then, disease states causing high triglycerides, hypothyroidism, poorly controlled diabetes. And I'm going to stop there for a second. I don't know how you have all been practicing recently, but I certainly have been getting a lot of patients with high triglycerides. And to be quite honest with you, the treatment therapy for high triglyceridemia has been relatively narrow in terms of, using icosahexaene pentyl, possibly statins, possibly Welchol, possibly fibrates. But I have been really homing in on the GLP-1 agonists recently and the SGLT2 inhibitors to control those diabetes better. And I've seen a tremendous improvement in triglycerides. I had a patient 2 weeks ago, triglycerides of, 2 months ago, triglycerides in the 2000 range. I think he had familial hypertriglyceridemia. His HbA1c was 6.9. I put him on a GLP-1 agonist and his triglycerides went into the 2 to 300, some other therapy changes too. So, we do have armamentarium now that can help us treat that. HIV patients I discussed that, pitavastatin could be a good idea in that patient. Chronic renal disease, pregnancy are other disease states causing high triglycerides. These are some of the medicines that can cause high triglycerides. I think the point I wanted to make here was you don't use bile acid sequestration if your triglycerides are greater than 500. I talked about estrogen, cyclosporin we discussed, glucocorticoids, anabolic steroids, protease inhibitors, beta blockers, and long-term interferon treatment. These medicines can lower your HDL, beta blockers, retinoids, adding a glitazone to a fibrate, progesterone, anabolic steroids, trans fats for smoking. And medical conditions that lower HDL, insulin resistance, we discuss. Quitting smoking can increase HDL by 20% within 8 weeks. High carb diet lowers HDL, very low fat diet can be considered. So, what increases HDL? Well, estrogen, but, only in the right appropriate patient. And aerobic exercise and alcohol can do it too. So, I only want to take 30 minutes of your time today because I thought it was important to get through the information. If you had some questions, and you can certainly do that. But I think the reason why I chose this topic is because we seem to forget about everything else that causes high cholesterol. We are, I think, all very well versed on the treatment of what therapies are out there, but I think it's also important to make sure you remember those underlying diagnoses and underlying medical conditions that do really elevate the triglycerides, the lipids, etc. So, yes, most disorders are exacerbated by medical condition, and hyperlipidemia has been, in my experience, a clue to an underlying systemic disease disorder. Secondary causes may provide a clue as to why patients with primary disorders suddenly develop worsening lipid profiles. For example, patients who had like the myeloproliferative disorders. And I wanted to end up by saying, don't just start the statin. Always think about what you could be missing before that, that knee-jerk response. So I said to myself I was going to speak for only 30 minutes. So here I am at 6:31. I thank you all for attending the talk, and I hope it was somewhat useful, or maybe a quick refresher of what we do on a day-to-day basis. But thank you, and Kelly, I'll give it back over to you.
Thank you, Dr. Patel. That was a wonderful talk, and is a very good reminder to myself as well to not just treat, to actually go in and look at all the underlying conditions, secondary causes that there are. I have one question. If anybody who has a question, if you'll put your question into the chat, I will ask that. Dr. Patel, one question I have is, what is your threshold for discontinuing, beta blockers and diuretics when we've really ruled out all these other secondary causes?
Yeah, that's a loaded question, isn't it? It's always a risk.
For them, right? I know, right?
So that is a loaded question. I'm always weighing the risk-benefit ratio, and I don't know what, Kelly, what your experience has been, but I've generally not adjusted the beta blockers and thiazides classically, because I'm not sure how much they do affect the lipids. So classically, if someone's got CAD, I would have classically kept the beta blocker. If someone's got CHF, I continue the Lasix. But if I have other options, yeah, I think it's fair. If you've got a patient who's got no other issues, and then the thiazide, I'll change him over to ACE-ARB or a calcium channel blocker. No harm in that. If they have no CAD and I can use another antihypertensive, like again, ACE-ARB, calcium channel blocker, hydralazine, etc., there's no harm in doing that. So yeah, I think I do that as a last resort, generally speaking, in my practice.
Okay, thank you. Any questions that anybody has, please send to our chat. Another question, you had, Dharmesh, you had mentioned the pitavastatin being more ideal for HIV. Can you elaborate on that a little bit for us?
Yeah, the pitavastatin, I think it goes via gamma glucuronation. It's not affecting the cytochrome P450 metabolism. So it has classically been favored, especially in the HIV patients, for lipid management. However, always there's something about HIV patients. You got to be careful about HIV patients, especially if you're using the calcium score to predict risk, because HIV patients have soft plaque. So you'll miss, quote, atherosclerosis in an HIV patient because you'll miss soft plaque. But classically, I think pitavastatin is generally considered a relatively good option in that patient subset.
Thank you. Any other questions that anybody has? All right, well, we're going to give you back a good about 25 minutes of your time if there are no other questions. Thank you, Dr. Patel, for this wonderful presentation, and we look forward to more CELA Speaks.
Thanks, everybody. I appreciate it. Thank you.
Thank you all.
Thank you.